I think this is just your excuse to tell me that I'm not empathetic enough, but it's okay.
If you take some pearls away from this, Dylan, that'll be fine too.
I'm learning as much as everybody else is.
This material is for reference and educational purposes only. SimKit, its authors, and associates assume no responsibility for the utilization of any knowledge, materials, or techniques shown or described, nor do SimKit, its authors, or associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedure and processes in each individual patient.
Hello, welcome to the SimKit podcast. This is Dylan War. So we know SimKit prides itself on delivering procedural practice for high acuity, low occurrence procedures. However, today we are going to leave the land of Minnesota tubes, cricothyrotomies, and lateral canthotomies and discuss a different type of procedure. This procedure is one that occurs with more frequency than we may think, and it's one that doesn't get enough attention. It's a procedure that can be so impactful that it can influence the direction of care and the patient's subsequent hospital course. This procedure is the act of having a serious illness conversation. And after today's discussion, we hope that you will be better prepared to engage patients and their families in these often difficult conversations. Today, we're going to talk to Dr. Neena Kashyap, an emergency medicine trained and now palliative care fellow at Cooper University Hospital. She had the unfortunate luck to be a chief resident with me during our emergency medicine training and definitely honed her craft palliating me out of quite a few emotional breakdowns. So Neena, welcome to the show. What would you like to tell the listeners about yourself?
Thanks for having me. I don't think it's unfortunate luck to be chief resident with you. Fun fact is that me and Dylan also went to medical school together. So if you ever wanted to feel very academically incompetent, be on the same training path as Dylan War. But other than that, you got it right. We did emergency medicine training together, and palliative medicine is also a field that brought me a lot of joy. So wanted to pursue a fellowship to then be able to exist in both fields. And I think that palliative medicine, there's a lot of principles that I've learned in fellowship and through my experience that I bring back regularly to the emergency department. And so happy to be on the show and share some facts.
Anything about yourself outside of the world of medicine that you'd like to share with the audience?
Not too much. I have a dog. I play ultimate frisbee. I'm just a little sports jock, not to the level of Dr. Dylan War, but that's where I'm at.
Last I heard, you're a professional frisbee player.
I'm playing on a semi-professional team, which is fun to be able to get back to it after leaving it for a while due to medical school and residency. So really happy to be back in that world.
We do have fairly short attention spans in emergency medicine. So for the sake of our audience, let's dive in. This probably sounds like a very basic question, but I think it's essential to framing our discussion. What exactly does it mean to have a serious illness conversation?
It's pretty simple. It's any conversation that you're delivering any serious or potentially life-altering news. So this isn't for your patient who's vomiting and you're delivering the diagnosis of viral gastro. Although that's very uncomfortable and deserves some empathy and Zofran. But really, I encourage people to think broadly about what life-altering news means. Most people will come up with the death notifications, the new cancer diagnosis, those kind of serious illnesses. A lot of times really will cue us to understanding the importance of this conversation. But even something like an ACL tear for a teenager who's very involved in sports is life-altering. And you can use some of the same principles. You're not going to have an entire goals of care conversation with the 18-year-old with an ACL tear, but you can use some of the principles of being able to deliver news efficiently, empathetically, and helping support your patient with the fallout of that news. You can really be able to apply it to some of these more quote unquote minute conversations that aren't usually considered as serious.
From what you're saying, it does sound like we can apply this type of procedure to more than just someone who's very sick. It sounds much more universal than that. Is that what I'm hearing?
Yeah, absolutely. We could always be better about communicating in healthcare in general, and then also just being more empathetic providers.
I think this is just your excuse to tell me that I'm not empathetic enough, but it's okay.
If you take some pearls away from this, Dylan, that'll be fine too.
I'm learning as much as everybody else is. I think the framing of this conversation as a procedure gives us emergency medicine docs, the non-OR proceduralists that we are, a way to approach these challenging discussions. With that in mind, all procedures have indications. What are the indications for having a serious illness conversation?
You've got some serious news to share. And of course, their platelets are above 50. I'm just kidding. Thankfully, this procedure doesn't have a long list of indications and contraindications that you need to know. But it is important to think about this conversation as a procedure because it really starts to put us in the mindset that there are steps to follow and structure to be able to do this much more effectively. And this is all going back to there's been a lot of research and things that go into it that have built these structures. And I really strongly believe that something that contributes to moral distress and then burnout in our field is discomfort feeling like you're not doing a good job or being an effective provider. And I think oftentimes we don't necessarily get that much training into these conversations and how to have these conversations. And it's intern year and someone's go get the code status. The patient, their family, they don't really know what's going on. They're looking to you for guidance. You don't really know how to provide that guidance. That just sucks. It's not good for you as a provider. And making sure that you have some sort of framework to guide you through this process because they're tough conversations. They're very emotional. You never want to be in this position, right? It would be great that we would never have to have a serious illness conversation ever again because we can fix everything. But that's just not the reality. And bad things are going to happen to people and patients that we're not going to be able to fix. And really, the thing that we can control in this face of a very uncontrollable situation is how we guide our patients and their family. That's all within our reach.
I think you hit on a really challenging thing, especially I think for us as emergency medicine docs who love fixing things. So we see a patient who's really sick and we hope that we have the solution to their problem, which usually is more testing, procedures, interventions, admission, and having these conversations, which maybe go against our fundamental desire to intervene and help patients, may actually be better for them in the long run, which I think as someone who loves to feel like a fixer, this can be particularly challenging. And I bet a lot of our listeners too feel like they want to fix things, which makes these conversations difficult. I think especially to have in the moment when everything seems so acute. I guess before we go through your framework, do you have any recommendations on how we slow down and maybe better reframe that desire to fix patients, quote unquote,
Yeah,
if that makes sense?
absolutely. We're all overachievers. That's how we ended up in the field of medicine, right? And oftentimes not being able to fix things feels like a failure. And that's not true. There are things that are outside of our control in medicine. There's things that the medical system creates that are way outside of our control, but we just don't control everything that happens to the human body. And I think understanding that you are not necessarily personally responsible for the outcome and that is not your failure. People are going to die. People are going to get sick. That is the reality. Shifting your focus and your benchmark of success to making sure that you are caring appropriately and compassionately for a family in these situations and the patient, it shifts your mindset. Let go of the final outcome, right? The final outcome, a lot of times in my work, is death. And that is really tragic and really sad. And you can understand and acknowledge that this is a situation that we don't want to be in. But understanding that we're here, we can't change the fact that we're in this situation. What can we control? I think I really do believe that there are sometimes worse fates than death. And we, in medicine, with our medical technology, a lot of the times can put people in that unknowingly and without having these conversations and making sure we're controlling the process, not necessarily the outcome, I think is the best way of putting that.
Okay. Process-oriented solutions. That makes sense. Let's go through your framework. How, in general, would you approach one of these serious illness conversations?
There are a lot of different frameworks to this quote unquote procedure. You'll see things like the SPIKES framework, the REMAP method from Vital Talk. There's a lot of different ways. The unfortunate reality is that in the emergency department, we don't usually get time to have an entire discussion using these frameworks. We can't necessarily get A through Z of an entire goals of care conversation before you're getting interrupted. So I've learned through my fellowship training and then also being an ER attending is how to structure these conversations with bailout points to allow you to meet your patient where they're at and support them well, all while making sure that you aren't necessarily expected to spend an hour with this patient and the next dumpster fire rolls into your emergency department that you need to take care of, like you got to bail. You're just not in a space that you can protect time without any interruptions for it indefinitely. So we definitely have some frameworks, but I've adapted them in terms of my own ER practice on how to do it with bailout points.
Okay. And I think hearing that is reassuring because I think one of the biggest barriers to having these conversations is that sense of time. How do
Mhm.
we as EM docs take 5 minutes, let alone
Yeah.
10 minutes to have a conversation with a patient who's particularly sick or their family? So it'll be interesting to see how you distill this information for us in order to do something effective, but also efficient. Now, you said spikes, remap, and you mentioned Vital Talk. For the uneducated among us, what is Vital Talk?
Yeah, it's an independent organization that essentially it's a 2-day training on how to have serious illness conversations. It's fantastic. It's like a very generalized training, so it helps people in all fields, anywhere from critical care intensivists to outpatient pediatrics, like everything. I really recommend it if you have the opportunity to do it, if you can get CME money or anything like that to be able to go through the training. It just is a nice way of, again, making sure that there's structure to these conversations, teaching you how to do it as a procedure so that you don't feel as alone next time you're having these conversations.
Break it down. What are you doing? You're walking in the room, and then what happens?
Yeah, so I always like to say serious illness conversations start before you even walk into the room.
I'm already messing it up.
You're on like step 3 of the procedure. I'm just kidding. The prep work is really mental, and it's all it is to help you not become a jumbled mess inside the room when things, again, these conversations can go different directions, and you just want to make sure that you have done the work to essentially think about what's going on with the patient and really figure out how you want to say things. And what we usually call that is a headline, which is essentially, at the end of the day, it's a one-sentence, one-liner about what's going on with the patient and what are the implications of that. It needs to be free of medical jargon. It needs to be succinct. And that's essentially going to be something that you prepare before you even walk into the room. So say you have a patient came in with belly pain, some weight loss, you did not feel great about this, got that CT abdomen pelvis, and radiology comes back, numerous masses, unknown primary. You're seeing mets in the liver, you're seeing mets in the colon, kind of all over the belly. It can be a lot of information to dump on a patient, just like I did to you, right? Where they're like, what? And you're talking about masses, you're talking about different organs. Like, what does this all mean? Because that's really what the patient wants. They want to know what that means. And so a headline for a situation like that can be, unfortunately, the CAT scan showed that you have cancer in multiple spots. And I'm afraid that means it's the advanced stage cancer. That's it. Like, that takes all of that medical information and really distills it down to the basic points that the patient needs to know. Again, this is not the only information you're going to give the patient. It's just how you're going to start the conversation. So I always encourage providers to think about their headline before they go into the room. Because if you don't have that, oftentimes what happens is because we care so much and because we want to show our work and show how much we care, we love to give patients an entire medical encyclopedia version of what is going on with them. And at the end of the day, the patient has no clue what happened and has no understanding of what the implications for their care is or what's actually going on. So a headline is a way of really making sure that's nice and succinct.
Just in summary for our listeners, a headline is a summary of their medical condition and where it currently is and the implications for that patient specifically.
Correct. Yes. It's like really break it down. I use the word life support a lot to describe a lot of different avenues of care. A ventilator is just life support for your lungs. Vasopressors are life support for your blood pressure. Break it down to people, because when you're using words like someone's on life support, people understand that a lot better, that how serious this situation is. Or if you're using a bunch of different organs, you don't need to name every single organ this patient has cancer in. And no, that means that the cancer is at its most advanced stage. You don't have very much more information than that, but that's the information that you have, and that's going to give the patient a lot more information about the implications for their care. They're going to grasp that that's serious cancer because that's its advanced stage.
So you've walked into the room, you've delivered your headline. What comes after that?
You're going to walk into your room with your headline. I always liken it to like being a third-year medical student on sub-I, where you had to create your assessment and plan one-liner. Bring that intention to your headline. So you have that ready. You're going to walk into your room and you're going to talk to your patient. This can be different depending on where you're at. with your patient. If this is a patient, maybe not a new diagnosis, maybe a progression of their diagnosis, if this has been something that the patient or their family have been dealing with for quite a while, that's where you're going to start with trying to figure out where they're at in terms of their understanding. Be like, hey, what have you been hearing from the medical team so far? What has been going on before this hospital stay? That's going to give you a nice little understanding as to like where they're at. If this is a patient who's, oh yeah, this is my cancer oncologist, I'm now on second line treatment for this. This is the side effects, and this is very knowledgeable. That's going to be a different starting point for your conversation. So it just helps you understand where your patient or their family's at. Of course, a lot of times in the ER, we're the first people talking to the families. This is not something that's ongoing with them. So most of the time, the understanding that they have is what you've already talked to them about the couple times that you've seen them or when you did your HPI with them and told them what the plan was. And now you're coming back to deliver. I always like to frame the conversation with just like a simple, like, I have some serious news to share. It just helps people anticipate and hear a little bit better, where they're not necessarily just getting blindsided with the news immediately. Offer, especially in the ER where patients may have come alone, not necessarily expecting to get serious news delivered to them. Always offer to see, is there someone who wants to join by phone? Is there someone you want to be hearing this with you? And 2025, FaceTime, everything, like people can be in the room without being in the room, which is really nice. I mean, hey, we're doing this podcast across the country, right? Medical technology is doing well. And then you deliver your headline. So that's like how you walk into the room. And again, everything, I know it just took me probably 4.5 minutes to explain this whole thing. Takes about 20 to 30 seconds when you're actually in the room. So it's really not that much time. And by being intentional about creating the headline first, it helps you not get lost at the very start of the conversation.
Okay. So you've done your homework, you've thought about the patient, you've created a headline, you've given them a sense of where this is going, and you've brought the appropriate people into the room who need to be there, whether virtually or in person. And you've given them that news or told them what the clinical condition and expected prognosis or implication is for that patient. How do you navigate the next steps after that?
So the next step after you give somebody a headline is to shut up for just a moment. We all suck at this. Like, we give somebody bad news or serious news, and then we start talking a mile a minute about what's next. And for anybody who's ever been on the other end of that, like, you need a minute. You need a second to like process, digest, especially if you've just given a very effective headline, which is talking about the serious implications that their diagnosis just has. People need a second. And so usually after I give a headline, the first 15 to 20 seconds afterwards, I don't say a word. I just let the patient hear what I just said. And it feels like an eternity, but
Yeah, I
trust
can
me,
imagine.
15 to 20 seconds of silence isn't going to kill you.
It might kill me.
It really just gives your patient an opportunity to digest. And then there's a bunch of different, again, more mnemonics about how to support your patient past this. But really, you need to understand that the reaction that is you're seeing immediately afterwards is emotional. It's not rational. They're trying to process what just happened. Patients will oftentimes come a mile a minute with questions at you, like, how long do I have to live? Does this mean I'm dying? All this other stuff. And because we're so information focused, oftentimes we'll just sit there and try to answer every single one of these questions, when really the reality is this patient is having an emotional reaction. And oftentimes you can be like, what are you hoping for? What's worrying you? Asking questions back to those questions oftentimes gets you a little bit better of understanding as to where the patient is emotionally and how they're doing. So allow them that bit of silence to think through things. They're going to come at you with some questions. Sometimes people will cry. Just making sure that you're having an empathetic emotional reaction. We'll put something in the show notes about the nurse's mnemonics, which is essentially all these different ways that you can help patients with emotional reactions and respond to them. But a few key phrases that I like to use is, I can't imagine how difficult it is to hear this news, right? Just a statement about, yeah, this sucks. Or a lot of times, I wish we weren't in this situation is really fantastic. It just helps you align with your patient. And really, I think also a lot of times brings patients comforts because they understand that this is something that's weighing on you as well, right? You might not be the person who's
Hmm.
getting the cancer diagnosis. You might not be the person who's being told that their loved one may never wake up or has a serious condition. But this isn't easy for you too. And I think that sometimes helps the patient understand that we want to be able to help in a different way, but that's just not the reality right now.
I can imagine that there are instances where this news is, to put it like lightly, not well received. How, with the time crunch of the emergency department, how do you deliver news like this and allow patients and or their families to process an emotional response when it seems like it may take quite a bit of time for that processing to take place, or you feel like you're not going to be able to engage them immediately regarding next steps or plans or the rest of your framework here? How do you escape?
Yeah, no, this is your first bailout point right here, right after this. You've given your headline, you've helped them go through the emotional reaction and given them some empathetic responses to their very understandable emotional response. And this is where you get to, as a clinician, have to judge what I like to call the emotional thermometer, right? If someone's a 10 out of 10 in their emotions, they're not going to be able to have rational conversations about next steps. They're not going to hear it. It's just going to be a waste of time. It's going to overwhelm them even more. And so don't do it. You don't have to. That's the beauty of the emergency department, right? We're all a team. There's an entire hospital team that's going to come. We don't have to be the person that has to have all of these, go through all of the steps of this conversation. So if you're providing empathetic responses and you're seeing that they're just overwhelmed, they're a 10 out of 10 on this emotional thermometer scale, that's where you introduce what a plan is next, what next steps is in terms of very broad strokes, saying, hey, we're going to get you admitted to the hospital. The hospital team's going to come down. We're going to do more tests because there's a lot of questions that we still need to answer. And we're going to talk to you more about this in one day and setting up that next check-in point. And then you get out of there. That's totally fine, right? You have done your job by delivering the serious news effectively and in an empathetic way, and that's okay. You don't have to be the person that carries this all the way through in terms of different plans, especially in the ER, because there's a lot of uncertainty. A lot of times we don't have the full picture. So that's okay.
Speaking of stepping out of the room and ceding the rest of the care to the inpatient team, how do you make sure that transition works well? Like, what do you tell the admitting team, the admitting residents, the admitting attendings when you're handing off that care regarding the conversations you've already had, if that's even applicable?
Oh, yeah, definitely applicable. The way you do this better is not just slam the admit button, never think about this ever
Full
again,
send.
and then
Yeah.
move on with your, right? Move on with your life, right? It's a warm handoff for the patient. It's saying, hey, this is what we talked about. I told them that this is what the likely next steps are, or plan maybe a family meeting. Oftentimes, if I'm talking to the patient and their family about how critical they are, I set up a family meeting for the ICU. I say, you know what? We're going to see how the next 24 hours go. And tomorrow afternoon, the ICU team is going to be reaching out to you guys to talk about where we are again. Because understand that this is all changing, right? If you think your patient's a little bit more stable, you can push that out to 48 hours, gives ICU a little bit more time to learn the patient and see what the clinical trajectory is. But by setting up that family meeting, I'll talk to the ICU and I'll be like, hey, these are the people I talked to. If you've figured out what the family tree looks like, if you figured out who medical decisions are going through, tell that to the ICU. That's important information. Set up that family meeting for them so that the ICU has a check-in point to talk to the family. Always saying that, of course, if things change earlier, we might need to have the conversation earlier. But setting up that second check-in point really helps the inpatient and ICU teams be able to care for this patient and really set up more continuity for the patient and themselves.
Warm handoffs. Sounds good.
Talk to your inpatient team. I
Yeah,
know.
talk to your inpatient team. That's a big barrier.
They're nice. Don't worry. They're upstairs. It's okay.
I'm trying not to laugh hysterically. From hearing you speak, another branch point that I see is after this delivery of information and the processing of this emotional response, you either get out of the room, deliver your plan, warm handoff, or we are delivering this news with the intent of making a medical decision. How do we handle what comes after the emotional processing when the conversation needs to go down a path of medical decision making, not just updates, if
Yeah,
that makes sense.
absolutely. I think a lot of times patients are going to, and their families are going to impress you. You're going to give that headline. They're going to have an emotional response. You're going to be able to empathetically support them again, maybe a minute. And then they're going to be able to come down themselves. They're going to be able to regulate themselves down on that emotional thermometer because we're humans. We want to know what the plan is. We want to know what next steps look like. And then they're going to be looking to you to talk about what's next and what implications are. And this, again, varies widely depending on what information you're giving. If it's a new cancer diagnosis, a lot of times medical decisions do not need to be made right now, right? We don't have enough information to be making medical decisions. So those are people that you're going to support them empathetically, talk about the plan of more testing and the uncertainty, and then send them on their way to the inpatient team. Or if you have great coordinated care, sometimes outpatient, which I have not been able to coordinate, but some people can. If you have a great setup system, this can be an outpatient workup, but I don't work at that hospital.
That doesn't exist.
But in reality, if this is a more critical situation, think about your patient who comes in, urosepsis, already on multiple pressors, going to the ICU. Those are patients where you're like, I don't think this is going to go well, or this is already not going well, and I'm concerned about it. So let me explore. If the patient and their family are giving me an opportunity because they are looking for next steps, let's take that opportunity to explore just a little bit about maybe what the patient and their family are looking for and hoping for their care, because they'll surprise you. A lot of times people, although they necessarily, when people are like, oh, do you have a living will? Do you have an advance directive? Everyone's, no, we've never had these conversations. But there are ways to explore where patients' priorities and values are that a lot of times people have thought about these things without necessarily having formal conversations about them before.
So you're talking about values and what patients and their families want. How do you ask those questions in a succinct and directed way in the emergency department setting to kind of get to the information you want for their care?
So I think there are different ways of trying to open this conversation up. Oftentimes, if you're dealing with like surrogate decision makers because the patient is so sick, I always like to think is like, have you guys ever talked about what would happen if this patient got so sick? A lot of times people are going to be like, no, I've never talked about that. I like the question, has anybody close to this patient ever been so sick? Have they seen anyone going through life-supporting ICU therapies? And that oftentimes is a big conversation starter, because if you've personally gone through it, a lot of times that's where your lay population sees the non-Grey's Anatomy version of what medicine looks like. That's where they're like, oh yeah, like I saw my grandmother hooked up to a bunch of machines in the ICU for days, and then she eventually died in the ICU. And during that time, when I was just chatting with my family, I was like, oh God, I would never want this for myself. Those phrases matter. Those are the patient seeing the non-glamorized version, seeing the realities of medical technology and making a value judgment for themselves, being like, whoa, like this is not something that I want for myself. Again, maybe grandma wanted that, so fantastic, all the ICU care, right? That was their priority, but maybe not the patient's. And so sometimes exploring if the patient has ever had someone close to them go through serious illness is helpful. If it works as well for like people who've seen other people go through cancer treatment sometimes, because they have a close understanding as to what cancer treatment can look like and the side effects of cancer treatment. And oftentimes it's just a jumping off point for that conversation. Be like, what did they say about that? If thinking about the patient and their family, asking them like, what's important to them? Is being awake and interacting with your loved ones really important? Is that still important if you wouldn't be able to get out of bed? Like, where is everyone's line in the sand as to what constitutes good quality of life? And sometimes framing it as a spectrum, saying that some people want time on the clock no matter what condition they're in. Some people never want medical interventions and want their symptoms and pain to be controlled and to not have anything done. And most people fall in the middle of that. And when they lose certain functions, at that point, they don't want medical interventions to continue to prolong their life because it's not a quality of life that they enjoy.
Do you have a couple other common phrases that you use during these conversations? As someone who is a little uncomfortable engaging these conversations, it would probably help if I just had some in my back pocket that I could look at a mirror and memorize the crap out of them, just so I know how to deliver these.
Yeah. One phrase is I always say, has anyone close to the patient ever been sick and in the hospital for a long time? And then
Cool.
asking afterwards, what did the patient think about that? Did the patient talk about anything that they wouldn't? I, a lot of times, will introduce the spectrum of quality of life, essentially, just like I did, of like time on the
Mhm.
clock is one end to symptomatic management only to the other end, and try to explore like, are there certain functions that are important to you that if you weren't able to do, that would, not be a quality of life worth living to you? Also, seeing if anybody else has gone through that decline with them. I oftentimes stay curious during these conversations. Like, I think a lot of times we get somebody to get a response and then we say, okay, and then we just move on. But like a lot of times asking questions, I know it's like the most annoying palliative care thing, but we answer questions with more questions a lot of time. If the patient themselves were sick earlier and then maybe got better, like what was that time like? Having those questions really explores just who the patient is as a whole. Again, they're going to say things like I did at the beginning, right? I have a dog. I play ultimate frisbee. I'm an active person. Those are values that I'm already saying without necessarily saying them directly.
I guess just to close this segment here, how do you practice for this? We, as physicians, can take home a model and perform cricothyrotomies. How do you practice these things? Because like this happens live, and it's fairly challenging if it's not something you do routinely. What advice do you have for the people that want to feel better about these conversations before they happen?
It's a hard question to answer. I think by
Being more emotionally intelligent,
yeah,
is that the
to be
answer?
fair, like the answer is that again, like even through my training, right? I sucked at this at the beginning. I was
Hmm.
better than your average person at it probably, but even before I did fellowship training, like I sucked at it. Like I wasn't great at recognizing the opportunities to continue to push those questions that we need to push back on. But really, I think by having a little bit more of a structure to it about making sure that headline's delivered effectively, by using principles like staying curious. And if you don't necessarily understand what a patient means, ask them. I feel like sometimes we feel so uncomfortable being like, wait, what do you mean by that? Challenge them a little bit. Be like, if they say something that like doesn't really quite make sense, or you don't completely understand the context to, especially when you're trying to explore their values, they might say something like being in bed was hard. You're like, hey, when were you in bed? What was that like? Like, use that opportunity to start to ask those questions. I wish there was like a textbook you could study and just be better at these, but it really is just more experience. And maybe for your first, I don't even know how many conversations, you're just delivering the headline, giving an empathetic emotional response, and then being like, okay, inpatient team, and then piecing the heck out of there. But over time, so you're going to start to recognize the opportunities to ask a little bit more about patients' values, direct this conversation a little bit. And it really does come with a little bit more experience because I would say that intern year, I couldn't have these conversations because I wasn't necessarily confident I knew the patient's clinical
Mm.
trajectory. That comes with clinical experience. When I was like, oh, yeah, maybe this very frail 90-year-old who's on a bunch of pressors, maybe they're going to come out of their 3-week ICU stay and that's going to be totally fine. And like now I've seen that so many times where now I have the clinical understanding that I know what 4 days in an ICU does in terms of deconditioning. We've seen those things. And that's how you better direct those conversations because you also understand the clinical trajectory a little bit more.
You've delivered your headline, you've listened to their emotional response, you've figured out what's important to them. How do you take those values or what matters and act on them at this point?
Yeah, this is where you become the patient's guide. The aim is that you're making a medical recommendation based on what you know, what you have trained for many years in medical school, in residency training, and your vast clinical knowledge. Based on what you know about the patient, the time you've taken to explore what's important to them, who this patient is as a person, now it's your time to be able to recommend a path forward, right? And sometimes in the ER, again, we are just diagnosing things, things are very uncertain, but there are medical recommendations that you can make, right? If someone expresses the fact that being in the hospital for a long time is not what they want to do, that they don't want to die in the hospital, that they had somebody go through a really long ICU stay and they thought that was horrible and they don't want that, make a medical recommendation, right? If this is someone who is escalating your urosepsis, escalating on pressors, make a medical recommendation that if their heart were to stop, that we allow them to have a natural death and we don't try to do anything to resuscitate them. And please, God, do not ask them if they want everything done, because yes, everyone wants everything done. People don't understand what everything means. And that's something that like we get really uncomfortable with medical recommendations around not taking all the life support that might be offered. We really shy away from that. But you don't diagnose somebody with a UTI, give them a list of antibiotics and be like, choose whichever one you could pronounce, have fun. You make a medical recommendation based on your knowledge of their clinical condition to make a recommendation on what antibiotic they should take. This is the same way. When you've taken the time to understand the patient, you're almost practicing a little bit of compassionate paternalism. It is really difficult for a patient and their family to be able to understand the entire clinical condition. They don't have your clinical experience. They don't have all of the training you've been through. So they're looking for you for some guidance. And it's really hard to put this on them as a decision that they're making. And they're making without any sort of support. But if you know a patient's goals and priorities, you can make recommendation. They can say, no, that's totally fine. That's not a big deal. But oftentimes I'm saying, like, hearing that dying in an ICU is something that you saw and that you don't want for yourself. If your heart were to stop, I would recommend that instead of using chest compressions and electricity to try to restart your heart, at that point, we allow you to have a natural death. A lot of times people will be like, yeah, that's what I wanted. Like, I didn't want chest compressions and things like that. That's such a better way of presenting that information with framing their values than to have it without any sort of guidance.
I'm just reflecting back on some conversations I've had with patients, and I'm like, I've probably messed that up a couple times. My takeaway here, at least a couple of them, it sounds like I need to, 1, be more emotionally intelligent, 2, stay curious, and 3, I like the phrase compassionate paternalism, which is definitely different from shared decision making. Why don't you summarize what we've talked about the best you can for our listeners here? If they could walk away with a couple key points or a couple key components of this framework for their next shift, what would you tell them?
So I know I've just been throwing a lot of information. I have not had an accurate headline this entire podcast and really have been overloading you with information. But the takeaways of this is prepare for these conversations, make a headline. That's very important. Make sure you're responding to the emotion that your patients are going to give back to you, because if you effectively deliver a headline, they will be emotional, and that deserves to be supported. It doesn't take too much time and makes us feel much better as providers. And then if you get that opportunity to get to know your patient a little bit better and get to know what their priorities are, don't leave them out to dry. Help them understand where they're at in their clinical trajectory and help them come to some decisions about their care, right? A lot of times, like, we might not know everything. We might say, oh, I don't know where this is going to go. But a lot of times if patients are super sick and are ER going to the ICU, we know that there might be futile care that gets offered as quote unquote everything that won't necessarily change their overall trajectory. And the flip side of that is it's prolonging the dying process and can be potentially causing harm to the patient. So don't hang them out to dry. Don't make them try to figure that out for themselves. Get to know your patient if you have the opportunity, and then be able to make a recommendation.
Neena, thank you for taking the time to talk to us today about serious illness conversations. I know my next shift, I'll definitely be thinking a little bit more deliberately about these interactions, and I will be sure to prep a headline before I go into the room and look a total fool. So thank you for this time, and best of luck with the rest of fellowship.
You're going to do great, Dylan. Thanks for having me. This was really fun.
Have a good day.
All right, I'll see you, Dylan.